My name's Amber Fisher, and I currently am working in acute care down in South Jersey. I see pediatric through adult patients. It's a small community hospital. I've been there about 5 years, and I'm also our rehab manager. I currently work at a small community hospital in South Jersey. It's called Inspira Health. Since we started having COVID patients, it's moved from seeing, so I would say I see less patients in a day because I spend more time also coordinating with other departments as different things have come up. Before therapy got involved with patients, I was in a lot of meetings with physicians and nurses and even our case management and social work, figuring out what our plan would be and what the process would be moving forward regarding PPE and optimization of how we're going to use PPE. I had to develop a new exercise program that we could hand out to these patients, which is similar. I've done that for other patient populations before, but this was now coming up with something new. And then also, I've been invited in to help with proning when nursing and respiratory needed some assistance. So sometimes therapy is involved in that, and that's a non-skilled, non-billable kind of aspect to the job that wasn't there before. So we've been seeing stages 2, 3, and 4 as they're at the hospital. Our biggest thing is that we're not seeing patients, if they are in the ICU, we're not seeing them until they've been extubated, unless they've received a tracheostomy and they're on a vent. Then we are going in and seeing those patients as they're deemed medically stable to at least start the early mobilization, which is similar. We would see all patients that were medically stable before, and this is one change. Going from our vent mobility protocol has kind of shifted to only working with tracheostomy patients on the vent. But we are seeing them at that high critical level all the way to patients that just have that generalized weakness, or they've been there so long and they've moved from ICU and they're out on the acute floor and they're getting ready to either go to rehab or go home. So when it started, we were getting some information from our facility of different patients. And then I attended the one webinar through AOTA, and I've also reached out kind of looking with my peers through, ASHA and APTA, kind of collecting some information, and everybody's kind of shared what we found together. And since I was our first therapist to start seeing patients, I've then shared my experience with the rest of the staff, and then also any information that I've found helpful moving forward. So some different articles that have been posted and out there. So the interventions, it depends definitely on where they are functionally. Some of the more critically ill patients, we are doing our basic early mobilization. Can we sit edge of bed? Can we help with your respiratory status? And one of the biggest things I've been focusing on within my first couple of visits, if I can, is working on compensatory breathing strategies to help, because the respiratory status seems to be the biggest limitation. And a lot of our patients we're seeing are on high flow nasal cannula, and they're having really a hard time working themselves back down. And then if they can't tolerate and, sitting without, using these strategies, I'm not ready to move on to ADLs. So kind of get them educated on the compensatory breathing. And then as I can progress with them, can we start doing some ADL things? Are we able to, do you have to sit, and kind of working on, if they're going to go home, what are some of the strategies with this weakness that they have that they can, implement at home as they're regaining their strength with home care. Many patients going into rehab facilities, that more patients are going home. Especially in the beginning, a lot of local facilities weren't able to accommodate COVID patients. So, we're one hospital for our county, and then there's usually so many facilities. And at first there was one subacute rehab in the area that was able to accept patients. Now it's kind of expanded, but a lot of people would prefer for their loved ones to go home. So we've had to do a lot of the communication with case management and social work, figuring out adaptive equipment and how to get these patients home safely if they're not going to go traditionally to rehab where we normally would send a lot of our patients. And then in my area, we also have a large number of uninsured patients. So those patients are definitely going home. So trying to focus on, okay, our plan is rehab. Ideally, we want patients to go to rehab for their recovery. But if they do need to go home, what is the safest way? What do they need for going home? Like, if they do have that poor endurance, should we make sure they're getting set up with a commode, make sure they're getting the walker and a shower chair, different things that they're going to need, which is usually we don't like to think about, well, everybody should just go to rehab. We don't want to think, oh, these people actually have to go home. So what's the alternative plan? And we've had a lot of family members that prefer to take them home. If they're working from home, they can take care of their family member at home. So kind of shifting our thinking a little bit. I would say the biggest thing is keeping up with different discussion boards and talking to other clinicians. That's been the most helpful to me is, oh, so what are you doing? Maybe it's something different in a different facility to kind of compare, are we doing the same things? And I would also say reaching out to physicians and nurses that are on the units and work with the same patients. They seem to have a really good insight into what's going on because they're definitely more in it than I am. I'm still seeing non-COVID patients throughout, my week with my caseload. So it's good to kind of go back. Is there any new information? I definitely keep checking, AOTA and with my friends or my other coworkers on APTA, what other information are they able to get? And we all kind of share and kind of discuss if there's anything new coming up. I would say one of the biggest things is, take a deep breath, remember what our focus is. And one of the biggest things I've noticed is the isolation that, there's no visitors, and especially we're going in completely covered. They're only seeing this little bit of our face, how they're feeling emotionally. I've had a couple patients that said, I feel really lonely and I feel really sad. But that's something we can understand and we can work with helping with the coping. Like, we shouldn't forget, these are so physically and medically ill patients, to not forget the psychosocial part that we can help out with too. And, have you spoken to family? Do you need help? Some of them that are too weak to use their phones, can we help them? Things to kind of help them feel a little bit better. That's one of the biggest things, is remembering what other things that we can bring to the table as OT professionals.